Hi, I'm Mike, and I'm joined with Cris today. And today we'll be doing part 3 in the Dell Hand series, and we will be introducing a new case. So we see lots of patients in the clinic with various hand diagnoses. We've talked about a both bone forearm fracture. We've talked about some ulnar nerve issues. Today we're going to talk about an individual where she had a fourth metacarpal head fracture as a result of falling on some stairs in her boat. And we saw her, and then a couple weeks went by. She went on another boat trip, fell again on those same stairs, and refractured her fourth metacarpal head.
How much time was there between this?
About 5-6 weeks.
Oh, man.
So it was a string of bad luck for this young lady. And we have a few videos that we're going to go to kind of reference here in a minute. But before we go to those, just want to review a couple of pieces of anatomy as it relates to her. So, fourth metacarpal, right? So far we have only drawn the first dorsal interossei, the first lumbrical, and then the first palmar interossei. But we have referenced the fact that the intrinsic muscles are not the same on every finger or on every digit. So we're going to bounce to digit number 4, knowing that the intrinsics are not the same on every digit. So the first thing that we've got to review is for the ring finger to adduct, it will move to
The long finger.
the long finger. For it to abduct, it moves to
Pinky finger.
pinky finger. So the muscle, the intrinsic muscle that's going to be on the radial side of the ring finger will be what?
The intrinsic?
Yeah, will it be a palmar interossei or a dorsal interossei?
Palmar interossei.
It'll be a palmar interossei, exactly right. So how do you know that?
Because we want it to go medial, and most of those muscles are going to be typically on the volar side. If we want to go lateral, those will be on the dorsal side.
So, right. So if we are going to go into the medial direction, in this case for the ring finger, the center post is the middle finger. So we're going to adduct it. Palmar interossei are responsible for adduction. So we're going to have a palmar interossei that's right on the radial side that will adduct the digit. And then conversely, on the ulnar side of the ring finger, it's going to abduct. So will we have a palmar interossei or a dorsal interossei on the ulnar side?
It'll be a dorsal.
Dorsal interossei. Exactly right. So we can start off by knowing that for this patient, her palmar interossei and her dorsal interossei will likely be involved to some extent. We had also mentioned last week the lumbricals. The lumbricals are unipennate to digit number 1, digit number 2, bipennate for 3 and 4. Median nerve innervated to 1 and 2. So lumbricals number 1, lumbrical number 2 are median nerve innervated. Lumbrical number 3 and number 4 are ulnar nerve innervated. And they are bipennate. We also learned last week that the lumbricals are always on the radial side of the hand. So always on the radial side of the hand. So on the radial side of the ring finger, what other structure do we have that joins with the palmar interossei?
On the dorsal side or the volar side?
On the radial side.
Oh, we have the interossei.
Interossei, and then the palmar interossei, and then it will be the lumbrical, because the lumbrical's on insertion to the radial side. So for this young lady, metacarpal head fracture, that's the bony part that's injured. The soft tissue parts that we'll take a look at will be palmar interossei, dorsal interossei, and lumbrical. So now we just need to figure out which number of lumbrical, palmar interosseae, and dorsal interosseae. So dorsal interosseae number 1, dorsal interosseae number 2, dorsal interosseae number 3 on the ulnar side of the middle finger, and then dorsal interosseae number 4 on the ulnar side of the middle finger. I'm sorry, the ring finger. So dorsal interosseae number 4 would be the one that's involved for this young lady. Palmar interosseae number 1. There are no palmar interosseae to the middle finger. Palmar interosseae number 2. So associated with her fourth metacarpal fracture would be incorporation or involvement of dorsal interosseae number 4, palmar interosseae number 2, and then lumbrical number 1, lumbrical number 2, lumbrical number 3. So the intrinsics involved with the ring finger will be palmar interosseae number 2, lumbrical number 3, dorsal interosseae number 4. So now we know what we're dealing with. And the lumbrical is bipinnate. So a lot to kind of take in there. So what we're going to do first is I'm going to draw in a little bit of where we ended last week. So if we do EDC, let's try that again. So if we have EDC just to the ring finger, shown here, then EDC to the middle finger, EDC to the small, and then EDC to the index. So all inserting into the base of the dorsal aspect of P2. All right. Then we also drew last time the sagittal bands. So we're just going to draw the sagittal bands. Ooh, I like that green. Here on what would be the ring finger. So those would be the sagittal bands and then the transverse fibers here in the orange. And that's about as far as we got last week for those structures on the extensor hood. But then we also drew in the dorsal and palmar interosseae. So for the ring finger, there is no dorsal interosseae to the radial side of the ring finger. However, there is dorsal interosseae on the ulnar side. So we'll show insertion into bone, tendon of the dorsal interosseae, and then its muscle belly. So this would be the superficial belly of dorsal interosseae number 4. It would be responsible for abduction of the digit. Then we could draw in the deep belly that will attach to the transverse fibers. And the deep belly is also bipinnate. So similar to our drawing on the index finger, we have the superficial belly shown by the circle going into the bone, and then the deep belly, transverse fibers, and then it gives off a little extension there that will connect with at a later time. But both the deep belly and the superficial belly lie between the small finger and then the ring finger. Questions to this point?
So this kind of looks very familiar, right?
Yeah. It's just a different orientation on a different finger. So this is responsible for abduction of the digit this way. And this makes sense when it comes to power pinch because it's joining together the ring finger with the small finger to get power grasp. Okay? Now, this would be on the dorsal side. Now we have to draw the structures that would affect the volar side. So before we do anything, we have to draw in flexor digitorum profundus because it is the origin of the lumbrical. So typically, FDP has a common muscle belly to the middle finger, ring finger, and small finger. And then it has an individual proximal muscle belly to the index finger, shown here. So individual typically to the index finger, combined muscle belly to middle finger, ring finger, and small finger. So now that we have drawn FDP, we can draw in the lumbrical. Now, lumbrical will come in on this radial side, okay? But it may help us to draw the palmar interossei first because the palmar interossei come off bone. So palmar interossei are unipennate coming off the radial side of the ring finger, and then the tendon going right into the first web space. So the palmar interossei shown here comes off the mid shaft of metacarpal number 4 and then sends its tendon in the web space between the middle finger and the ring finger.
So its tendon's just hanging on to what, subcutaneous tissue?
So its tendon goes in there, and it's going to join another structure here in a minute that we haven't drawn.
So it's just like the other ones. Okay.
So this is the part that I think is pretty cool. We'll draw the lumbrical here on blue. So the lumbrical comes off the corresponding muscle bellies, because it's bipennate, between the middle finger and the ring finger, and it sends its tendon right alongside the palmar interossei. The two of them join together in that first web space, and once they join together, they form the lateral band that comes right in that web space. That lateral band joins with the lateral slip. So in this web space here, we have the tendon of palmar interossei number 2 joining with the tendon of lumbrical number 3 to form the lateral band to join with the lateral slip. And then on the ulnar side, this little spit off the dorsi interossei extends as the lateral band and joins with the lateral slip. So that part is a bit dense.
It's very similar to the thumb and the index, though, in
Very.
terms of origin, insertion, where it goes, and
Right.
what's there. Yeah.
So why is all this important clinically? So we're about to see in this case study why it's important. So we're going to start off with our patient doing an exercise, and what we've asked her to do is to pick up a pom-pom and then flick the pom-pom. So let's watch this and then we'll pause. So if you just look at her hand here, let's look first at her small finger and tell me what you notice about her small finger.
It's kind of stuck in PIP flexion, and I can't tell from really this far because I'm blind, but DIP might be either neutral or slightly flexed as well.
Yeah. So let's run it again.
Yeah, and it doesn't fully extend, it seems.
Doesn't fully extend, and when it flexes, it's inclined to rotate there a little bit.
Let's see, one last time. I do see that rotation at the very end.
Okay. Now, what do you notice about her middle finger and her ring finger? Even
Well,
her index finger. You can kind of see it here with the video stopped.
the index and the long fingers seem like they're hyperextension of PIP and DIP,
Yes.
and then the ring finger looks to be actually like a swan neck deformity.
Yeah, so she has hyperextension, the PIP joint of all of her digits. So swan neck deformities on all the digits. She's not seeing us for her swan neck deformities.
Yeah.
She is seeing us because of her fracture. So she is seeing us because of a fourth metacarpal fracture. We make her a splint. She's coming out of her splint for exercise. We see this in some other problems. So under one hand, we can say, hey, the fracture's doing well. Your hand can get better with time. Or we can kind of dig in a little bit and say, why isn't the small finger working the way it's supposed to? Why isn't it extending at the PIP joint? And why is it kind of rotating there a little bit? And why does it kind of stick out a little bit? So it kind of, the gap between the ring finger and then the small finger is greater than normal. So we'll keep running the video here for a moment.
Oh, that have something to do with the opponent's muscle of the pinky finger? Because that's responsible for the rotational aspect. But also, I guess the abductor would be I don't know. That's weird. Tricky.
It is a very tricky one. So to help us kind of solve the problem in this video, we can just keep it playing and then we're just going to keep talking. So in the video, we're trying to figure out in our mind why is this not working the way it's supposed to work. We go back to this exercise and we also apply electrical stim
To the dorsal interosseous?
to the dorsal and palmar interosseous. So we put a small electrode here on the dorsal side and a small electrode here on the volar side. And what we're after doing is trying to stimulate dorsal interosseous number 4 and palmar interosseous number 2 and lumbrical number 3, because we know that all three of them have significant contributions to PIP joint extension. So our thought is that maybe we'll just give them a bit of a jump start. And so when we give them a bit of a jump start, we see her finger straighten out. We see it straighten out and we see
The pinky
come back. Not perfect, but we see it activated. So with that being the case, what does that tell you? That if you put stim on it, the motion is better. She has better PIP joint extension and she has better adduction.
Well, what setting did we have it on?
35 pulses per second. It was on for 10 seconds, off for 10 seconds, pulse width of 300.
So we're trying to get a strong muscle contraction.
Yep.
So if we're not getting a contraction or the information is not being relayed through the brain, that's what was missing, right? That's why we were in that position.
Yeah, so somewhere along the line there might be some muscle inhibition, so a muscle re-education that needs to take place. So next, she tells us something interesting. She says, if I hold my index finger, middle finger and ring finger straight, I can do a better job at home at straightening out my pinky finger and I can bring it closer together. So we thought, okay, that's curious. So we put little ovalate splints on each of these fingers to correct the deformity. Mm-hmm. Applied stim, did the exact same thing that we had just done with the stim on. This time we added ovalates to hold the PIP joints in extension, or essentially to try to correct the swan neck deformity. she's able to straighten out that PIP even better, bring it in, adduct it even better. So then we're like, okay, that's curious.
Interesting.
Now let's remove the stem, leave the oval 8s on, and see how she does. Does a great job of extending the PIP joint actively and adducting it with the oval 8s on. So we've kind of glossed over that a little bit, but this case illustrates the importance of understanding the intrinsic anatomy and the extrinsic anatomy. So if we think about what happens when you hyperextend the PIP joint or when you have a swan neck deformity. When you have a swan neck deformity, the lateral bands that we have just started drawing here, those lateral bands go in the dorsal side of the digit. So they creep dorsally, that brings the digit into PIP joint into hyperextension. So when the digit's in hyperextension, then it changes the mechanics of the finger. It also changes the position of the extrinsics and the intrinsic muscles. So if we think of it maybe as like a differential of a car or four wheels, so as cars have advanced over the years, if one wheel is sliding, then the automobile has the ability to
adjust its power distribution.
Adjust its power distribution to other fingers or other wheels.
To keep you working as good as you can, yeah. Okay.
So we're introducing at this point, haven't delved into this yet, but the lumbrical has more proprioceptive fibers than any other muscle in the body. Some recent papers have helped us to understand the proprioceptive input or value of the lumbrical. Meaning the lumbrical has the ability to help be this differential.
So it's pulling back on what it's doing or adding more to what it's doing to kind of make up or assist in wherever way it needs to?
So it has the ability to govern itself that way. It also has the ability to distribute to the extrinsics, intrinsics, or basically say, dorsal interosseae, we need more of you. Less of you, palmar interosseae. We need more of the FDS, FDP, less of EDC, or more of EDC, less of FDS. So it's this modulator between structures. So if we take that concept, or somewhat of that kind of hypothesis, and apply that to this case, when we put the oval 8s on each of the digits, what we did is we corrected the position of the extrinsics and the intrinsics in resting position to better funnel the force distribution of the lumbrical to the ring finger and small finger.
Because it almost thinks everything's back to normal. Yeah.
And as a result, we directed the force distribution back to the small finger because these were in a healthy position. And as a result, we appreciated improved IP joint extension and improved adduction.
I guess I have two questions about that. First being, so what does that look like for that person, I guess, might be the only example, to get back to as close to what it should look like? Is this like something she's got to
So for her, no, exactly right. So for her, all exercise should be done with oval 8s on, because what that does is it normalizes the balance so that she can control the force distribution to the small finger. What was happening without the oval 8s on and without the E-stem, the force distribution is all directed to the hyperextension of each of those digits. And as a result, it's not there for the small finger. Correct the position, neurologically you're able to send the signal because mechanically you're in the right position. So it was a neurological issue, a neuromuscular issue, but a neuromuscular issue that was able to be enhanced with NMES and corrected with corrected posturing.
So is that, in a sense, Does the lumbrical, I mean, I guess this answer is no, but does the lumbrical have something within it that makes it different than other musculature that we can identify, or is it purely better at getting the information from the brain to itself and then taking that joint proprioceptive information, relaying it back to the brain, and then making its adjustment hyperly, quickly?
No, it's the former. So the number of muscle spindles and the orientation of the muscle spindles in the lumbrical is what makes it unique. That allows it to control the joint position. So it's the architecture of the muscle that makes it unique. So similar to the mouth, similar to the eyes, the muscle fibers are kind of more ocular or circular in their orientation, and that is a high proprioceptive count in those muscle fibers. And so the actual physiological architecture of the lumbrical is unique so that it is designed to help pick up those proprioceptive nuances.
So then in some sense it has some level of memory, is kind of what that sounds like.
Well,
If it's not having to relay, it's just picking up information and then responding. Right?
I think we're learning that.
That's crazy.
I think we're learning. And then, maybe I made this example last time, but if you think about if you're working on a car or something where your eyes are occluded and you're having to, screw a nut onto a bolt. If you think about your hand, unbeknownst to your sight, has to modulate this very fine degree of force, flexion and extension, add and adduction, without you seeing it.
Yeah.
So we're suggesting the lumbrical is a key something to allow that to happen. And when mechanically there's a fault, then it creates challenges. And then this would be one of those such challenges.
That's fascinating.
So kind of a cool case.
Definitely.
When we watch the rest of this video, it's one worth talking about. But we'll kind of close by this exercise, because this exercise is it's a good assessment tool and a good piece of exercise to activate the intrinsic muscles. So we ask the individual to reach, grab the pom-pom. So if the pom-pom was between, in our scenario, the ring finger and the small finger, there are specific muscles that have to do this. Dorsal interosseous number 4, palmar interosseous number 3, lumbrical number 4 are going to grab it. They're going to have an isometric hold. We're going to supination, so supinator brings it over. We're going to ask the patient to isometrically hold, so dorsal interosseous number 3, dorsal interosseous number 4, palmar interosseous number 3, and lumbrical number 4 are activated, while FDS and FDP are activated. Bring it down to a fist. We ask them then to extend. So as soon as they extend, EDC, EDM, lumbricals, and then dorsal interosseous number 4, palmar interosseous number 3, lumbrical number 4 are all activated for IP joint extension, and then abduction, and then adduction. So it's this great orchestration of intrinsic and extrinsic muscles on a very simple exercise.
Does this fancy exercise have a name, or are we just calling it pom-pom?
Intrinsic pom-pom.
Okay.
It's intrinsic pom-pom. Yeah.
That's a good one.
So, all right, questions on this segment?
No, I got them out kind of as they came to mind. I like that one.
Yeah. All right, so this concludes this segment.